Welcome to this short revision class on endometrial cancers. We will see endometrial cancers under these headings. The risk factors, most of the risk factors finally lead to unopposed estrogen exposure, either exogenous or endogenous. Endogenous causes would be early menarche, late menopause, nulliparity, which means more number of menstrual cycles and more estrogen. Metabolic syndromes, which are associated with obesity, will mean increased peripheral conversion of testosterone to androgens to estrogen. So unopposed estrogen exposure, even in postmenopausal women. There are other risk factors which are unrelated to this, like Lynch syndrome, familial Lynch syndromes, or pelvic radiation. Now, histologically, endometrial cancers can be endometrioid or non-endometrioid. The endometrioid types are broadly considered as low risk types, good prognosis types, and the others are bad prognosis types. A better and a more modified classification would be endometrioid carcinoma, which can be of low grade, grade 1 or grade 2, or mucinous carcinoma. Mucinous type of endometrioid carcinoma or high-grade endometrioid carcinoma. And then there are other carcinomas like serous, clear cell, gastrointestinal kind of mucinous carcinoma. All of these are high risk or more aggressive or high-grade cancers. So low-grade cancers, this is very important for the new FIGO endometrial cancer staging of 2023. Low grade, because it includes terms like low grade, non-aggressive, aggressive, high grade, all those things. So low grade is just endometrioid carcinoma, grade 1, grade 2, and mucinous carcinoma. Whereas high grade endometrioid, serous, clear cell, mixed, undifferentiated carcinosarcoma, other unusual types, and gastrointestinal mucinous types are high grade types. Traditional classification or Bookman classification of endometrial cancers is type 1, which is 75% cases. Mostly these are endometrioid. They have a history of unopposed estrogen exposure, either endogenous or exogenous. And these are low-grade tumors, better prognosis, microsatellite instability, PTE, and CTN, B1, all these molecular markers may be present. The other type, on the other hand, is less common, seen in older women. Unopposed estrogen exposure is not there. It is estrogen independent, may arise from atrophic endometrial also. So this is more common in the postmenopausal group. Molecular classification, again, is important for the new staging because molecular classification can modify the staging of FIGO endometrial cancers. These molecular classifications broadly, it was much elaborate in the previous papers, but now they have classified into 4 simple types: pole mutated, MMRD is mismatch repair deficient, NSMP is non-specific molecular profile, and P53 abnormal. Pole mute has the best prognosis, MMRD intermediate prognosis, NSMP has intermediate to excellent prognosis, and P53 abnormal has the poorest prognosis. So you classify them as pole mute, MMRD, or P53, and when none of this is found, you call it NSMP. Now, as I said, the molecular classification has been very elaborately explained elsewhere, but this WHO article on histology gives a nice table on the classification, molecular classification. You can go through this, but the most important part is the prognosis part and how it modifies the staging. Now, staging has changed and has become more extensive. Stage 1 is confined to the corpus and may extend up to the ovary if other indicators of spread beyond the uterus is not there. So 1A is limited to the endometrium or non-aggressive histologic type. If it is non-aggressive, it can include the inner half of the myometrium or low-grade endometrioid type. So 1A1 is non-aggressive, limited to the endometrium. 1A2 is non-aggressive, involving less than half of the myometrium. 1A3 is low-grade, but limited to the uterus and ovary, which means it can include the myometrium as well as the ovary. 1B is non-aggressive with more than half of myometrial involvement, and 1C is aggressive, confined to the endometrium. If it is aggressive and gone to the myometrium, it goes to stage 2, unlike the previous classification. So this is stage 1. Stage 2 is when cervical stroma is involved or substantial LVSI is there, which is more than 5 lymph vessels involved, or aggressive histologic type with myometrial invasion. 2A is non-aggressive cervical stroma involved. 2B is substantial LVSI of non-aggressive type. 2C is aggressive with any myometrial involvement. Stage 3 is local or regional spread. 3A is serosa, adnexa, or both. 3B is vagina parametria. 3C, I have underlined the same things. 3C is lymph node involvement. 3C is pelvic or para-aortic lymph node. 3C1 is pelvic. 3C2 is para-aortic. They are further classified as micrometastasis or macrometastasis, which I have explained here. 0.2 to 2 millimeter size or more than 200 cells is micro. Macro is larger than 2 millimeters. Stage 4, bladder mucosa or beyond that. Stage 4A is bladder bowel mucosa. 4B is abdominal peritoneal metastasis beyond the pelvis. When it goes beyond the pelvis, it is 4B. And 4C is anything beyond the abdomen and the pelvis. Molecular classification and the staging. So molecular classification, I told you that it can modify the staging. It can modify staging only of stage 1 and stage 2. If it is stage 3, whatever molecular classification is there, pole mute or P53, the stage will not change. But in case of stage 1 and 2, this stage changes if a molecular classification is found. So if it is pole mutated, you know that it has a better prognosis. So pole mutated cancers involving the cervical stroma are not stage 2, like we discussed before. The staging will be downstage to stage 1, and you will write it as 1 AM pole mute. Right. 1A is the staging, and M stands for molecular classification. And if it is P53, confined to the uterine corpus with any myometrial invasion, with or without cervical invasion, it becomes stage 2 instead of stage 1. So stage 2C, because it has a P53 abnormality, whatever the grade, whatever the type of histologic classification, if it has P53 abnormality and any myometrial invasion, you write this as 2C M P53 abnormal. This means there are two kinds of women with a diagnosis of endometrial cancer, one who has undergone molecular classification and one who has not undergone molecular classification. If she has not undergone molecular classification, you will not use the staging. If she has undergone molecular classification, if she is stage 3, 4, you will not use the staging. If she is stage 1, 2, you will check if she fits into any of these, then you will reclassify. All right, management is very simple, depends on the stage. Up to stage 2, confined to the uterus and the cervix, the first treatment is surgical staging, which includes hysterectomy, BSO, peritoneal washing, lymph node staging, and omental biopsy. And depending on this, you will decide on adjuvant treatment. Adjuvant chemotherapy or systemic management will not be given in stage 1 low-grade cancers, or when there is pole mutation, it is stage 1, you know that it is a low risk patient and you can skip adjuvant therapy. For all other patients, adjuvant chemotherapy is given. Examples are stage 1, high risk molecular classification, like it is P53. If it is P53, anyways, you will classify up stage to stage 2 if there is any myometrial invasion. Stage 1C, all cases you will give adjuvant therapy. So all stage 2 cases will require adjuvant chemotherapy. Or if you initially thought it is stage 1 and 2 and you did surgical staging and you found out that lymph nodes are positive, that is stage 3, you will give adjuvant chemotherapy. Now, if she's stage 3, which means it has gone beyond the uterus, it has gone to the vagina or to the adnexa, then the management, then the surgery which you do for it is not called surgical staging, because on imaging, you already know that she is stage 3. So here what you do, when there is extension beyond the uterus, what you do is, what you do is debulking, TAH-BSO with debulking. And in all these cases, stage 3 and 4A, you will always give adjuvant chemo with systemic therapy. For 4B, when it has gone beyond the pelvis, when there is abdominal involvement or it is beyond than that, you give systemic therapy. Now, the last part is which cases you can give fertility preserving management. Fertility preserving management can be given in endometrial cancers in stage 1. Most important point of this slide is who is the ideal candidate for fertility preservation management. So it should be a well differentiated grade 1 endometrial. All these words are important. Well differentiated, it should be grade 1, it should be endometrial. So it cannot be serous variety, it cannot be intestinal mucinous variety. Disease limited to the endometrium. MRI should have been done. Absence of any metastatic disease. No contraindications to medical therapy, which is going to be high dose progesterone. No contraindications to pregnancy. And then you have to counsel the patient that this is not the standard treatment. We don't know if your prognosis is going to be similar to the standard management. It can be worse. What do you do? How do you do fertility preserving management? Very important step is hysteroscopic resection of the lesion has to be done. You can't just do a check curettage, identify it as well differentiated stage 1, grade 1 endometrioid cancer and decide fertility preservation management. You have to do further surgical management with hysteroscopic resection and then do proper imaging for the staging. And after that, when you're satisfied that she fits into the criteria, then you start continuous progesterone therapy, which is high dose, which is medroxyprogesterone acetate, 400 to 600 mg per day. Now, mind you, we give 10 mg per day to 30 mg per day maximum for abnormal uterine bleeding. Here, you're giving multiples of that dose, 10 times higher or even 20 times higher dose. or megestrol acetate 160 to 320. LNG-IUS, intrauterine device, can also be inserted after hysteroscopic resection. Some people say that if you do hysteroscopy, you push in a lot of saline under pressure, you can cause positive peritoneal cytology. But mind you, if you see the staging, peritoneal cytology does not upstage the tumor. Also, it doesn't affect the survival or the prognosis. So hysteroscopy may be done in these cases. That's all on the short revision of endometrial cancers, dear students.